Introducing you to people across North Carolina and around the world who put their Catholic faith into action. This is Faith Works on Catholic 540 AM Divine Mercy Radio. Now, here's your host for Faith Works, Ellen White.
Hello, everyone, and welcome to Faith Works on Catholic 540 AM Divine Mercy Radio. Our show highlights individuals through God's grace that put their faith into action every day. Amazing people who have an interesting and sometimes overlooked impact on our Catholic faith. On Faith Works, we share their stories. I'm your host, Ellen White. Super excited to be continuing our conversation with Dr. Patrick O'Connell. This brand new series, dubbed Doctor on Call, will be a once-a-month discussion on current medical topics and Dr. O'Connell's practical medical advice from a Catholic perspective. So listeners, take advantage of this awesome opportunity to have your medical questions answered for free. Write to us at info@catholic540am.org with any medical questions you'd like to have the good doctor answer. We especially enjoy the Q&A segments of the show. So such a great way to get connected with you and your concerns. Do not hesitate to write in. Again, that's info@catholic540am.org, and we'll mention that again at the end of the segment. So Dr. O'Connell, for those of you that are not aware, has been practicing medicine in the Raleigh area since 2006, joining Duke Health as a primary care physician, and in 2017, founded Sentinel Primary Care here in Raleigh. Dr. O'Connell has a certification in Catholic healthcare ethics from the National Catholic Bioethics Center. Dr. O'Connell is an underwriter of Divine Mercy Radio. Okay, so for this show, we had discussed a variety of different topics, and it seemed like summertime was the theme that we touched on. So since we're in the midst of July, which is so weird because the time has passed so quickly and it just doesn't seem like July except for the heat. For this show, we'll talk about various things that are associated with summertime. Tick bites, heat exhaustion, hypothermia, and poison ivy, which is something that's, I wouldn't say near and dear to my heart, but something that I experienced not too long ago.
Me too.
And we'll touch on COVID with some updates on that. Not too much from the good doctor. So welcome, Dr. O'Connell.
Thank you. Good to be back.
It's good to be chatting with you again. So let's start with tick bites and what we can expect from that and what to look for.
Yep. Yeah, so ticks are a big springtime and summertime issue. You go out into nature and ticks are looking for you. And of course, the concern is ticks can transmit infections. So, I think the one everybody is the most aware of is Lyme disease. But there's a couple of others worth noting. So sort of the overview is I'll break ticks into two size categories. There's big ones, which is kind of your normal tick, your dog tick. And then there's the really little ones that may be too small for you to even see. That the big ones, which are dog ticks and Lone Star ticks, carry one group of infections, and then the little ones are the ones that can carry Lyme disease. So Lyme disease first, the tick is often so small that people never knew that it bit them. They get this rash, they're like, what the heck is this? They go to the doctor, and the doctor's like, oh my gosh, you have Lyme disease. And the person's like, how's that possible? I didn't get bitten by a tick. And it's just because the tick is so stinking small that you never saw it. You never knew that it was there. But so Lyme disease, we're not in the heart of Lyme disease country. You go further north, you get through Virginia up towards DC, and further north from there, you're entering the epicenter. So there's not a ton of Lyme disease in North Carolina, but you can get it here. You can get Lyme disease in North Carolina. So the general rule of thumb here is if all of a sudden you're like, where the heck did this big red rash come from? Well, that could be Lyme disease. You want to get that looked at. And from a clinical standpoint, you look at it and that's your diagnosis. So you don't do a blood test for it. You just look at it and say, that looks like it may be Lyme disease, and we treat it. In fact, the blood test is usually negative at that point.
Well, like a question about that. So since the tick is so small, does everybody experience this rash or have some kind of indication?
No, not necessarily. So 80% roughly of people who get infected with Lyme disease develop the rash. About 20% don't. So, and that makes it tough because then, some of the downstream weird things that this bacteria can do occurs. And it's like, what the heck is this? Where did this come from? And then it can take some diagnostic work to figure out like, oh, this is Lyme disease. But so, yeah, it's only 80% of people who develop the characteristic rash.
What are some of the other symptoms that people can expect to experience with Lyme disease?
Yeah, so in conjunction with that early phase when people have the rash, a lot of times people just don't feel good. You may have a low-grade fever and just sort of feel achy, and that's your immune system fighting against the bacteria that gives you that kind of feel. And so to varying degrees, that can occur in conjunction with the rash or soon thereafter.
Okay. So that's the itty bitty tick.
Yep.
Lyme disease. Now, what about the big old ticks that you see?
So the big ones, like these are the ones when I was a kid, you'd pull them off your dog and it was like this little grape that you just pulled off. It was so gross. So one species is the Lone Star tick, and you can impress your friends because you can identify the Lone Star tick by the white spot on its back.
Oh, interesting.
So you can say, oh, that's a Lone Star tick. And your friends will be like, ooh, wow, you know stuff. But so that one, interestingly, it carries an infection that looks for all the world like Lyme disease, but it's not Lyme disease. It gives you a red rash, indistinguishable from Lyme disease. And we treat it the same antibiotic as Lyme disease, but it's not Lyme disease. And it doesn't have the long-term sequelae as far as we know. But so that's one. The other one is the dog tick, which is, again, that larger size tick, and it's just plain brown. So this one carries Rocky Mountain spotted fever. Now, Rocky Mountain spotted fever is not common, but it's more common in North Carolina than it is in a lot of other parts of the country, and it is comparably common here as it is in the Rocky Mountains. So this is an important one to be aware of. Rocky Mountain spotted fever will initially show up with a fever and a headache, and then over the subsequent couple of days, the spots of spotted fever begin to show up. But the problem is by the time people start getting spots, they're desperately sick. And so the general approach, like what I do in the office or a common emergency room approach in summertime in North Carolina, is if somebody comes in with a fever and a headache and I can't explain why, I will oftentimes empirically start treatment for Rocky Mountain spotted fever. Sort of a shoot first, ask questions later, because delayed diagnosis is bad.
What's the treatment? What do you do?
First line is doxycycline, which is an oral antibiotic.
Oh, okay. Well, since we're talking about insects, and we didn't even broach this before the interview, what about spiders? Black widow, brown recluse.
Gosh. Willies. So one thing I'll say, spiders get blamed for way, way more than they deserve. So like sometimes people get a boil, like a bacterial infection, and it will be called a spider bite. But almost every single time something gets called a spider bite, there was never a spider involved. It's a bacterial infection that caused an abscess. That being said, brown recluses, which are reclusive, so they tend to kind of hide in corners and under clothing and in shoes and such, their bite can be nasty because it can cause tissue destruction and an ulceration. Black widows, which also tend to be kind of reclusive and underneath things, like they're in the wood pile, they're underneath, a bunch of leaves. Their bite can be quite nasty as well and cause severe abdominal pain and can be pretty dangerous. Fortunately, these are not super duper common. They're out there. I've seen black widows eye to eye, and they would definitely wig me out. But fortunately, the bites are not super common. Okay. And like I said, most things called a spider bite are not.
Yeah, I've seen the black widows as well, and they look like a plastic spider with a red thing on their back.
Yep, they're very glossy.
Their spider webs are unique too. They're very thin. I don't know. I know when we have them in the garage because of the spider web and what it looks like. I've obviously had a lot of experience with them.
Yeah, sounds like
okay. All right, so let's switch gears from the insects to hyperthermia or heat stroke. It seems to be a common issue in the summertime in North Carolina because it's so stinking hot.
So here the issue is getting overheated, and to the point not just of being uncomfortable, but it being a medical problem. So heat exhaustion, heat stroke. So I had no idea until I was researching this for another reason a couple of years ago. But when you're outdoors in the heat and you're exerting yourself, you're doing heavy yard work or exercising, you can get your core body temperature up to 101, 102 degrees. And you feel hot, but it's not like you feel like you have a fever, but you can really get your temperature up. A correlate to that is if you are 150-pound person and your body temperature is 102 degrees, that is a lot of heat energy in your body that you have to get rid of to get your temperature back down. So temperature regulation it's a big effort to be able to be out in the heat. Essentially, the avoiding dangerously overheating, heat exhaustion and heat stroke is important to do because some of the risk factors that go with it very much apply to North Carolina and the modern age. It's a hot environment, a humid environment where you don't, sweat doesn't evaporate very well, not being conditioned to the heat. So, if you're a Monday through Friday in the office and Saturday, Sunday outdoors, you're not conditioned to the heat. And so it hits you harder because you're not adapted to it. The points of advice here are, so hydration is super important from a heat regulation standpoint, because essentially if you think about it, if you use a car analogy, your skin is the radiator, your blood is the radiator fluid. So your blood vessels in the skin dilate, deliver lots of warm blood to the skin, and radiate away the heat, either directly through radiant heat or indirectly through sweat and evaporation. So it's important to have enough radiator fluid in the system before you go out and expose yourself to the heat, and then to stay hydrated as you get out there. Because what happens is you're sweating and the sweat's pouring off, and as you become dehydrated, now you have less fluid available to make sweat, and you have less radiator fluid to get the blood flow to the skin to radiate the heat away. And then your temperature starts going up, and you start getting yourself into the range of heat exhaustion and heat stroke. So heat exhaustion, you can sort of use the term loosely to say, I'm overheated, I feel crummy, or you can use it in precise medical terms to talk about cardiac output and is it adequate for muscle exertion and blood flow to the skin and all that. But the idea of it is you're just asking too much of your system, and your body temperature is getting up and your system can't keep up with it, and you feel bad. But the delineating factor is your brain still works. Because as you crank your temperature up, you get up to 104, 105. Now your brain starts to malfunction. And now you're talking about heat stroke, where you transition from something that's very unpleasant to something that's dangerous. So if you're outdoors and you feel crummy, then you need to go back inside and cool off and realize, like, okay, I'm not acclimated to this and I'm probably dehydrated. And it's going to take me a while to cool down. 5 minutes inside and my skin cools off, but my core temperature is still 102 degrees. Go inside, cool off, spend a little time, and get rehydrated. So,
is there a certain ratio of amount of fluid that you need to be drinking, water that you need to be drinking with the amount of time that you're spending outside? Obviously, paying attention to the signs that you might be experiencing some overheating, but is there a certain amount that you need to be drinking to make sure that you're hydrated enough? I know that there's, without getting too descriptive, you can look at your pee, and if the pee is a certain tone, you know that you're hydrated enough. But other than that, what about with fluid intake?
Yes, I don't have any set number in mind of how much you should be drinking. But, when somebody is really sweating heavily outside, I mean, you can lose a lot of liquid quickly. Okay. I don't know what the numbers would be. I bet it's a quart an hour, 2 quarts an hour would be my guess. But yeah, you can lose a lot of fluid.
Just make sure you're staying hydrated. And if you get overheated, get inside.
Yep. And the other comment is a lot of sports drinks, they got too much sugar. And they're not great. If you go for the Gatorade, which is kind of the knee-jerk reflex, Yeah, like 1/3 Gatorade, 2/3 water, and because you don't need all that much sugar.
Yeah, I'm a runner and I've done some marathons, and when I did my first one, it was recommended that you do the Gatorade at certain intervals. And as I was learning, I realized that I actually felt better when I was drinking water as opposed to Gatorade with the running.
Yep.
So now, what about with the sodium? I've heard some discussion about the sodium in these sports drinks. Is that good for you? What's the deal with that?
Yeah, so the idea is when you're sweating, you're not just losing water, but you're losing minerals or electrolytes, so sodium and potassium and chloride. And so the idea is with just straight up water, you're replacing the water, but not the electrolytes. And so Gatorade, for example, was an early attempt to kind of formulate something that would more closely replace what you've lost. There's other formulations that have been, tweaked better. A lot of them don't taste very good though, because they taste salty to you. But the idea is just straight up water is good, but the longer you're out there sweating, you may end up disproportionately losing sodium and potassium and chloride, and only replacing the water.
Okay. And again, so listeners, I'm sorry to interrupt you there.
No, go ahead.
If you're tuning in just for the first time, I wanted to reiterate that this is a new segment called Doctor on Call with Dr. O'Connell, and we're just touching on various medical issues that we might be facing today from a Catholic perspective. So if you have any questions, please don't hesitate to write in at info@catholic540am.org. Okay, moving on in our discussion, let's talk about poison plants, ivy, oak, sumac, that we might have encountered in our gardening in the yard, what to look for, and what we might experience if we have a reaction and treatment.
Yes. So I hate poison ivy so much. It's just funny, but way back when I was in medical school, I got exposed to poison ivy. I was too poor to go to the doctor. So I decided I'm going to treat this with hydrocortisone over the counter, which is just worthless. That is such a wimpy steroid. But I knew from my dermatology rotation that if you put a plastic occlusive dressing like saran wrap on a steroid, it makes it more potent. So I would put on hydrocortisone, wrap up in saran wrap, and try to sleep and not scratch. And it was awful, just awful. A disastrous attempt to be my own doctor. Anyway. But yeah, so contact with these sets off a really intense immune system reaction. You get, with heavy exposure, with a dense exposure, you'll get blistering at the site of the exposure, fearsome itching that can just drive you insane. And the reaction, untreated, will go on for 2 to 3 weeks. Not at full strength. It'll fade over that time, but it'll take 2 to 3 weeks before it's totally done. So if you know what the plant looks like, then avoidance is helpful. But a lot of times you get exposed without realizing it because it's in a brush pile of other stuff. So then if you can get the oils washed off pretty quickly with soap and water, then you can avert reaction. But then once the reaction gets rolling, it's like, oh boy, here we go. And so now, interestingly, there's a perception that you can spread poison ivy, which there's some truth to. Like if you've got the oils on your hands or on your work gloves, yeah, you can spread it as long as you keep touching new surfaces with that contaminated glove or hand. But once you've washed it off, you stop spreading it. But what does happen, the heaviest exposed areas break out first, and then as the immune system ramps up its response, then very lightly exposed areas begin to break out as your immune system's like, hey, there's some over there too. Let's go get that poison ivy as well. And then that area, on your back where you just lightly brush, now it breaks out 2 or 3 days later. And so typically with poison ivy exposure, you get a rolling outbreak that goes on for 3, 4, 5 days. And it's not necessarily the person is continuing to spread it. It's that lightly exposed spot was destined from the beginning to break out, but it was going to take a few days to.
Does it spread through the bloodstream?
Does not. Well, practically speaking, no, it does not.
Okay. So just surface area touching.
Correct.
Okay. All right. And can you spread it to somebody else? Well, I guess you could if you have it on your gloves and you touch somebody else.
Yes, exactly.
Okay.
No, again, same thing though. Once you've washed, once the clothing or the tools or whatever, once those are out of the picture, then you won't spread it to other people.
Okay. And treatment.
Hydrocortisone doesn't work, as I can attest.
No bubble wrap.
Medical school. No, please no. So typically, so some of the over-the-counter remedies are modestly useful for itching. So, calamine's the one we all think of, and it's reasonably helpful, but it doesn't fix the underlying inflammatory reaction. So to get at that's where you need anti-inflammatory steroids. So things like hydrocortisone, but 50 times more potent in the prescription category, or if it's a bunch of surface area and it's too much to rub cream over half of your body, then oral anti-inflammatory steroids. And these generally work pretty well. There's issues of side effects with oral steroids, but it works and helps to get things tamped back down to where you can sleep and make it through the day without clawing your skin.
And treating it inside and outside, I found, has been very effective for me when I get a bad case of it. All right. And the catchy phrase that I've always remembered is, what is it? Leaves of 3, leave them be. So any kind of plant that you see out in the yard that you don't recognize that has 3 leaves on it, don't mess with it, or you'll be itching. All right. Well, we're coming to the end of our segment, and I wanted to touch just briefly on COVID and what you've seen. I understand you've had some cases in your office, and, obviously with medical confidentiality, you can't share too much, but what has been your experience over the past couple of weeks, and what are these patients experiencing?
Yeah. So after a long stretch of just hearing about COVID-19 but not seeing anyone with it, I've now diagnosed several people with it. So it's out there, as we knew. And so the experience has varied. There's this spectrum of illness severity. I've seen one person with really mild, it's like an insignificant cold. Another person who had, kind of a bad cold, but not terrible. And then a third person is just like, doggone it, when's this going to start getting better? They just felt terrible for 2 weeks. But nobody's had dangerous illness among the folks that I've taken care of with it.
Great.
But it is certainly out there for sure.
Okay. All right. Well, good. Well, prayers for your patients and for all those in our listening audience that are experiencing any kind of illness, and for a speedy recovery. Okay. And listeners can go where to find you, Dr. O'Connell.
So the name of the practice is Sentinel Primary Care. So sentinelprimarycare.com, or you can Google my name and find me that way.
Okay, great. So we're coming to the end of Dr. On Call, and listeners, stay well. And remember, should you have any questions for Dr. O'Connell for our next segment next month, please email us at the station at info@catholic540am.org. And in the subject line, mention Dr. On Call. Thanks so much for tuning in to FaithWorks on Catholic 540 AM Divine Mercy Radio. Our special thanks to Dr. O'Connell for visiting with us today and for his wonderful advice. If you missed any part of our program, you can play our past shows by going to catholic540am.org and clicking on local shows. The Executive Director of Divine Mercy Radio is Cecilia Flannery. Our Director of Programming is Peter K. O'Connell. Our engineer is Keith Flannery. I'm Ellen White. God bless.